Good day. I'm going to talk about adverse anesthetic events. And there are a number of adverse anesthetic events, which include laryngospasm, stridor, hazards of blood transfusion, anaphylaxis, latex allergy, radiocontrast reactions, malignant hyperthermia, extravasation and intraarterial injection, inadvertent intraarterial injection, air and venous embolism, awareness, a delayed recovery, unable to reverse neuromuscular blockade, post-operative nausea and vomiting, and injuries during anesthesia, including peripheral nerve injuries and corneal abrasions. Because of paucity of time, I wouldn't be able to do all of them, so I will do as many as possible. Now, in each scenario, remedial measures include both prevention, treatment, and subsequent care to a referral center like an allergy clinic or a malignant hyperthermia diagnostic center. So to begin with, we will talk about laryngospasm and identifying the patient groups and the risk factors that can trigger laryngospasm can help us minimize this adverse anesthetic event. Anesthetic related factors include insufficient depth of anesthesia, and laryngospasm can also be encountered at tracheal extubation. Airway irritation, halothane and sevoflurane are least irritant, while desflurane is most irritant. Mucus blood manipulation with a suction catheter or during laryngoscopy can trigger an episode of laryngospasm. Propofol is less likely to cause laryngospasm than thiopentone. An experienced anesthetist is less likely to cause laryngospasm in children. Patient-related factors: children who have recently suffered from an infective upper respiratory tract infection have a tenfold increased risk of laryngospasm, and surgery should be delayed for at least 4 weeks after an upper respiratory tract infection for this reason. If with airway hyperreactivity, there's a 10 times increased risk of laryngospasm, which can last up to 6 weeks in a patient with active asthma, necessitating the delay for surgery. Tobacco smoke abstinence for 2 days reduces the risk of laryngospasm. And other conditions like obstructive sleep apnea, gastroesophageal reflux, and airway abnormality as encountered with tracheal stenosis, Pierre-Robin syndrome, and in Parkinson's disease can all trigger laryngospasm. Surgical related factors include a shared airway, a tonsillectomy and adenoidectomy carry the higher risk with a more than 20% increase in the incidence of laryngospasm. In thyroid surgery due to injury to the superior laryngeal nerve or due to hypocalcemia secondary to accidental parathyroid gland excision, laryngospasm can be triggered. With esophageal surgery, it is thought to be due to the stimulation of distal afferent esophageal nerves. There are certain procedures in which laryngospasm is more common. It's during appendicectomy, cervical dilation, hypospadias repair, skin grafting, and dilation of the anus and cervix. The presentation must be noted. It could be simple airway obstruction and inspiratory stridor, increased respiratory effort, a tracheal tug, paradoxical respiratory effort, regurgitation or vomiting, and identifying the presentation helps immediate management, which includes cutting off nitrous, giving 100% oxygen, removing the stimulus that precipitated the laryngospasm, removing irritants from the airway, deepening the anesthetic, considering Larson's maneuver. Ensure that 100% oxygen is given and CPAP is maintained. If the laryngospasm has occurred at induction, it may be relieved by deepening the anesthesia with further incremental doses of propofol, 0.5 milligram per kg, or increasing the volatile anesthetic. agent. Partial obstruction slows the uptake of the volatile anesthetic. If laryngospasm fails to improve, sucks 0.25 to 0.5 milligram kg IV can relieve laryngospasm. The sucks can be given either IM, sublingually, or intraosseously if IV access is not available. With regard to blood transfusion, there are many specific hazards, including TACO, TRALI, where you have acute lung injury, immediate and delayed hemolytic transfusion reactions, non-hemolytic reactions, which can be febrile and allergic, post-transfusion reactions, graft versus host disease, as well as iron overload. In each of these cases, there are strategies that can reduce the incidence of these hazards. As with TACO, careful pre-transfusion assessment of a patient for evidence of heart failure is appropriate. Calculation of the appropriate dose, especially in children. Monitoring, including the heart rate, the respiratory rate, the arterial blood pressure, and the saturation after transfusion are important. TRALI, the incidence of TRALI can be reduced with universal leukodepletion and the exclusive use of all male donors for FFP and plasma for platelets. Hemolytic transfusion reactions can be reduced by blood transfusion education and training, and robust policies and standard operating procedures relating to all aspects of transfusion to reduce the risk of mismatched transfusion. Acute transfusion reactions can be reduced with universal leukodepletion, which has shown to reduce the incidence of febrile reactions, and the use of pool solvent detergent treated FFP may reduce the incidence of allergic transfusion reactions. Post-transfusion purpura can be reduced with universal leukodepletion, graft versus host disease with universal leukodepletion and gamma irradiation of blood products. And the risk of bacterial and viral infection can be reduced with a thorough disinfection of donor arm and discard the initial flow of blood. As well as universal leukodepletion, which reduces the risk of viral transfusion, including cytomegalovirus and possibly prion diseases, measures to target hyperthermia, which include increasing the theater ambient temperature, heating and humidifying inspired gases using warm air blankets and fluid warmers. Acid and electrolyte disturbances can be monitored and corrected with serial arterial blood gases. The treatment I will not go through, but for each situation, appropriate treatment is required. For example, in a hemolytic transfusion reaction, crystalloid infusion, cardiorespiratory support with inotropes, return the unit to the blood bank and seek hematological support. Take blood samples from the recipient for full blood count, clotting, Coombs test, and repeat cross-match. Maintain a urine output of more than 100 ml per hour. Send urine samples for hemoglobinuria analysis, and treat DIC with clotting products. TACO, sit the patient upright, cardiorespiratory support as necessary, 40 to 80 milligrams of furosemide, monitor urine output, and take a blood sample for brain natriuretic peptide ratio. And for acute lung injury, post-transfusion, ventilatory support, moderate fluid restriction is appropriate. Anaphylaxis is another common adverse anesthetic event with medico-legal consequences. And so it is important to note the important risk factors, which include NSAIDs, muscle reactants, and beta-lactam antibiotics. Currently, reaction to dyes and chlorhexidine are becoming more commonplace. Diagnosis is important, and early recognition of symptoms, including cardiovascular collapse, bronchospasm, arrhythmia, angioedema, rash, and urticaria, which helps us commence management. Management includes ABC, maintenance of the airway, give 100% oxygen, treat with adrenaline, give antihistamines, corticosteroids, consider a catecholamine infusion, check ABGs for acidosis, give bicarb where necessary, intubate to protect the airway, and consider bronchodilators for bronchospasm. And this is a flow algorithm for anaphylaxis management. I won't go into the details. Here are the signs and the symptoms, and this is the differential diagnosis. What's important in this is once at the end, you must have a follow-up where skin testing and rust assays are done, and the patient is referred to an allergy clinic. A letter is provided to the patient with a detailed record of the drugs, the test results, and the future recommendations, with advice to wear a bracelet saying that he is allergic. Anaphylaxis follow-up includes referral to an anesthetic allergy clinic, having serum tryptase evaluation done, and doing RAS tests for antigen-specific IgE antibodies. In latex allergy, it is important to identify the high-risk population. These include patients who have had neural tube defects like spina bifida. The incidence of latex sensitivity due to recurrent bladder catheterization is high as 20 to 25%. Associated medical conditions include atopia, asthma, rhinitis, and severe dermatitis, which have an increased incidence of sensitivity. Occupations like those patients working in the rubber industry, as well as those working in the health industry, and fruit allergens where there is cross-reactivity with fruit allergens from bananas, just fruit, avocado, kiwi fruit, etc. Occupational exposure to latex increases the sensitivity in health workers, and this must also be taken into account. If a patient is suspected for having latex allergy, then the preoperative precautions include that all team members should be alerted that the patient has latex allergy. The operating theater should be prepared the night before, and the patient should be scheduled first on the list. This reduces the number of latex particles in the air. Latex allergy notices should be placed on the anesthetic and theater doors. Once only use latex-free equipment within the surgical and anesthetic areas. Remove non-essential equipment from the vicinity of the patient. Limit staff traffic during surgery. Resuscitation equipment must be latex-free. And further, in some hospitals, we wash down the theater walls and surfaces to minimize potential exposure, minimize airborne exposure. This is a list of breathing circuits, Goodell airways, CVP lines, ECG leads, blood pressure cuffs that are latex-free. This is a list of drugs that are available in latex-free stoppers. This is a pathway for investigating a perioperative allergic reaction or an unexplained perioperative reaction. It is important to note that if the surgery is a non-urgent elective procedure, we have to gather all relevant charts, and if allergy is suspected or no information is available, postpone the surgery, refer for allergy investigation, and follow advice from the allergy clinic. Whereas if in an emergency procedure, gather relevant charts, determine if the allergy is suspected, and identify exposures before reaction. If there's information is available about the allergen, avoid all exposures identified and use alternative drug. Consider the use of inhalational or regional techniques. Use as few drugs as possible. Avoid NM neuromuscular blocking agents. Avoid latex and disinfectants. Avoid penicillins and cephalosporins, and have a high degree of suspicion for the onset of early signs and symptoms of an anaphylactic or anaphylactoid reaction. Radiocontrast reactions can present as immediate hypersensitivity or as even as fatal anaphylactoid reactions. The incidence is less with low osmolar non-ionic solutions and more with high osmolar ionic solutions. The subsequent risk upon re-exposure for patients with a previous history of ionic contrast reactions is quoted at 21 to 60%. However, this subsequent risk can be reduced by tenfold if a non-ionic solution is used instead. Risk factors must be identified, including a history of asthma, bronchospasm, previous reaction to contrast medium, a history of allergy or atopy, and other risks include anxiety and the use of ionic contrast over non-ionic contrast. Prophylaxis includes pre-medication with a combination of antihistamines and steroids. Less than 10% risk of recurrence with pre-treatment. And if for elective pre-treatment, consider oral prednisolone and promethazine. And for emergency treatment, consider IV hydrocot and IV promethazine. The next adverse event we have is malignant hyperthermia. The trigger agents are SUCs and volatile anesthetics. If suspected, stop the administration of the volatile anesthetic, remove the vaporizer, increase the delivery of oxygen to maximize oxygen delivery and to promote elimination of both the triggering agent and carbon dioxide. Use activated charcoal filters if available. Otherwise, hyperventilate with 100% oxygen at 15 liters per minute. And when help arrives, change the breathing circuits and soda lime because it may get exhausted because of increased CO2 production. Maintain anesthesia with intravenous agents. The mainstay is dantrolene. Also, if in malignant hyperthermia, active measures must be taken towards active cooling measures must be taken to target hyperthermia. Continuous monitoring must be established, including an arc line and a central venous line. Treat hyperkalemia with insulin and dextrose. Consider 10 mL of calcium chloride. Acidosis is to be treated with sodium bicarbonate. Arrhythmias with amiodarone and beta blockers. And acute kidney injury is to be prevented with the use of liberal use of crystalloid, furosemide, and the alkalinization of urine. Treat disseminated intravascular coagulation as consumptive coagulopathy may supervene. Refer such patients to the malignant hyperthermia clinic for muscle biopsy and testing to caffeine. It is important to know the clinical signs of malignant hyperthermia. Tachycardia and tachypnea are early signs, whereas a rising core body temperature is an intermediate sign, and myoglobinuria is a late sign. This is a flow chart of what must be done in the event of malignant hyperthermia. Call for help. Inform the surgical team to complete the surgery ASAP. Insert a urinary catheter and check for myoglobin. Stop the volatile anesthetics, commence TIVA, hyperventilate, increase fresh gas flows to over 15 liters per minute. Use dantrolene, treat arrhythmias, active cooling measures, insert an arc line and CVP, renal protective measures, treat hyperkalemia, treat acidosis, and treat coagulopathy. In the event of accidental extravasation into tissues or an accidental intraarterial injection, it is important to know which drugs cause damage, either through vasoconstriction and ischemic necrosis, or from direct toxicity or osmotic damage, or from extrinsic mechanical compression by large volumes. These are hyperosmolar drugs. These drugs cause damage because they are either acids or alkalis, like aminophenol and amiodarone. And these drugs, like epinephrine and dobutamine, are vascular constrictors. Below is a list of specific drugs and the type of damage they cause. In the event of extravasation or intraarterial injection, the steps include stop the injection, disconnect the infusion, aspirate out as much drug as possible from the cannula, leave the cannula in place until for further treatment, and consider more specific measures. So the basic treatment is stop injecting. The principles of treatment are dilute the irritant, reverse the vasospasm, prevent the thrombosis, keep the cannula in C2. If the drug is administered was highly irritant, flush the vessel with isotonic saline or Hepsal. Administer local anesthetic 5 mL of 1% lignocaine to reduce the vasospasm and reduce the pain. Administer vasodilator like papaverine, and Also consider sympatholysis like stellate ganglion blocks, a guanethioidine block, and heparinization to minimize the risk of late thrombosis. The next adverse anesthetic event that I want to talk about is aspiration. And in aspiration, again, to reduce the risk of aspiration, we must identify the risk factors for aspiration. These include a full stomach, which can happen during emergency surgery or gastrointestinal obstruction, delayed gastric emptying from systemic diseases, including diabetes mellitus and chronic kidney disease, recent trauma, the use of opioids, raised intracranial tension, and pregnancy can all delay gastric emptying. An incompetent lower esophageal sphincter may be seen in hiatus hernia, in recurrent regurgitation, as well as in pregnancy. Morbid obesity can also contribute. Surgical factors include upper abdominal surgery, the lithotomy or head-down position, and anesthetic factors include light anesthesia, supraglottic devices, positive pressure ventilation, length of surgery more than 2 hours, and difficult airways. The use of first-generation supraglottic devices increases the risk of aspiration. Strategies available for reducing the aspiration risks include reducing the gastric volume. This includes preoperative fasting, nasogastric aspiration, and the use of prokinetic drugs, avoidance of general anesthetic, use a regional technique, reducing the pH contents through with antacids, H2 antagonists, proton pumps inhibitors, protecting the airway with tracheal intubation or second-generation supraglottic devices, prevention of regurgitation with cricoid pressure and rapid sequence induction, and extubation with the patient awake with airway reflexes reversed, either upright or in the lateral position. These are some recommendations by NAP4 on aspiration. Strategies should be used to reduce aspiration at emergence if the patient is at risk of aspiration. Anesthetists should be aware of the prevention, detection, and management of blood clot aspiration, as in tonsillectomy. An active measure should be taken when flat capnography trace occurs, when blood has been near the airway. Thank you. Just see where has the recording stopped?